Welcome to part 2 of lumps in lips. In part 1, we covered the details of how you assemble the story that allows you to make a diagnosis. That's the background of the patient, and it's the experience they had during the procedure, exactly how you did the procedure. Then it's the symptoms they've had since the procedure and the examination that you make on the day. Using those 4 different parts of the story and assembling a narrative that gives you a lot of detail is pretty much all you need to make a diagnosis, so long as you know the story of the common diagnoses that go with lumps in lips. So in this section, we're going to cover all the main types of lumps that you will see in lips, the story that goes with those lumps, and you should be able to relate that quite quickly to any patient who comes to see you with a lump, and you'll know what the problem is. And in section 3, we'll talk about how to manage each one of those lumps. There are 3 broad categories of lumps in lips. The first are lumps that are caused by the treatment itself. By that I mean the delivery method. So it's the process of placing filler in the lips causes trauma or may introduce infection. The second is the product-related or substance-related lumps in lips. I differentiate between product and substance because sometimes foreign bodies can play a role in lumps caused by lip procedures. And the final category are medical causes or non-treatment, non-substance related lumps. And those are just to be aware of, just so that you don't falsely reassure a patient who has a medical condition and a lump caused by that condition. So procedure related lumps can be divided broadly into 2 categories, trauma or infection. If we look at trauma first, trauma related lumps be divided into 3 categories as well. 1 is inflammation, 2 is a hematoma, and thirdly, a simple bruise. Infection-related lumps could also be divided into 3 categories, but usually in the early stages, it's either simple acute infection or a herpes simplex outbreak. Biofilms can come later and they can come at any stage, so that's the 3rd category. Now let's go back and examine the type of story you'll get with the main traumatic lumps that you'll see in day-to-day practice. So let's have a think about the likely story that will present with a hematoma. So looking at our different categories, we need to look at the patient, the procedure, the symptoms and the signs over time before they present with you. The patient who develops a hematoma may have no particular interesting story that goes with them, but it would certainly trigger you to think more about hematoma if you knew that they were on aspirin or have previously bruised badly, and that would make you think more that hematoma is likely. Secondly, if you look at the actual procedure, if you remember injecting them and there was a lot of bleeding and you seem to be using a lot more cotton swabs than normal, that's also a big indication that a hematoma will be likely. If you then look at the most important bit, which is the symptoms, mostly symptoms of a hematoma would be a little bit of discomfort straight after the procedure because bruising does cause inflammation, possibly more inflammation than standard, but then a gradual recovery in terms of inflammation. There certainly shouldn't be pain, but there could be tenderness because bruising causes tenderness. And the general trend from the point of injection over the first 24 hours will be a little bit of increase in symptoms and then a gradual tapering off because bruising is, once the blood is into the tissue, inflammation peaks and then starts to improve fairly quickly. So 24 hours afterwards, they should not be worse than they were right after the procedure. And that's a really crucial way to differentiate hematoma from other more serious causes. If we look at the examination of a hematoma, you're obviously going to see clear discoloration of the skin where the blood is situated. You also want to look carefully to rule out a lack of capillary refill by looking for blood flow wherever you can possibly find it, and also looking at the amount of tenderness when you examine. So it would be normal to have some tenderness, but you shouldn't have acute inflammation and you shouldn't have a decrease in capillary refill, which would all make you think of other diagnoses. Let's also now consider a very common follow-on from a hematoma, which is induration. The patient that gets a big bruise and maybe doesn't seek help because they thought that was normal, sometimes comes back 4 to 6 weeks later with another type of lump, which is called induration. If we have a look at the type of patient this might be, it's basically someone who's used to bruising, who has bruised, who has in their mind no particular problems after the procedure, but their symptoms might be that they notice this lump that just doesn't seem to be going away. On examination, when you have a look closely at this lump, you should feel a non-discrete lump. So induration is basically fibrous tissue that comes from the healing process, which is triggered by blood being present in tissue where it shouldn't be. So when you examine induration, you should feel a diffuse, difficult to feel beginning and end of the lump, and it can just feel kind of knotty or gristly, and it might still be tender because there's still inflammation in that area. So induration just needs time to recover, but it's important. It's part of the history of a hematoma, and you can reassure people, so long as the trend is getting better, that that's exactly what will happen for them in the future and no treatment is required. Now let's consider the story that you might get with an acute bacterial infection. First, if we consider the patient, they may have risk factors for infection, such as they may be taking a steroid tablet or possibly have an autoimmune condition that they are treating with immunomodulators, such as infliximab and various new products that come out all the time in that arena. Some people don't treat people on with autoimmune conditions, but the manufacturers do not rate it as a complete contraindication. So it may be that you've seen someone treated or treated someone who has a risk factor for infection. The second might be that the procedure was slightly different. Some people believe that the hole from a cannula is slightly larger and therefore might increase the risk of infection. Likewise, there might be something that your patient did or said that made you wonder about their ability to maintain great aftercare, and there may be a risk factor there which makes you think about infection a bit sooner. Finally, if we look at the symptoms and the signs, the symptoms of an infection would tend to be a little bit later on, within kind of 24 hours plus, as compared to other signs of inflammation. You can get signs of infection quite early, but usually it's within a day or two. If you think about how that would develop, initially there would be a normal swelling from the procedure. There may be then a slight decrease in swelling as normal recovery happens, and then something else would happen that would trigger a development pattern. So things are then starting to get worse for the patient. They might explain that they had increased swelling, they might have increased pain, and certainly some people describe other sensations such as itchiness or tingling around the area that then tends to be getting worse. So that's one of the key things with an infection. There seems to be an area where it's developing, the symptoms are getting worse from 24, 48, even 36 hours after the procedure. You can tell it's not going in the right direction. Following on further from that, they may even start to get discharge or discoloration or visible pus underneath the skin, and that's a clear, easy diagnosis for any clinician to make, but this is much later on. In terms of what you might see on examination, usually infection is more isolated. So you would see an area of redness and pain that's over one part of the lip, but not necessarily affecting both the top and the bottom lips. This is one of the key differentiators from allergic reaction, is that you're more likely to have infection in one area because the body is generally quite good at isolating infection, but it can spread. But that's also what you'd be looking for in the story, which is that it started here and it's spread to somewhere else. That's also would go a little bit more with what you'd expect from an infection. Occasionally, infection takes a hematogenous route to the cause rather than through the procedure itself. And what that means is someone who has a dental infection or a sore throat, there is a chance the bacteria might settle on the filler and then start to grow in that area. And so sometimes infections from these procedures can come months after the actual procedure was done. And it's worth remembering that when your patient complains of pain and swelling in an area of dermal filler and you haven't seen them for 6 months, it could still be a complication that you should deal with. The next really common type of infection is herpes simplex. Now, if you break down the details that you're likely to have with this case, the patient themselves will probably have reported to you that they sometimes get cold sores. This is always worth documenting, and if they get cold sores regularly, you may consider giving them prophylactic acyclovir. But even with these measures, it's possible that an outbreak would happen. So the patient will have told you about the history. Next, if you consider the procedure, it's likely to have been a procedure that affected the vermilion border, although you could trigger a cold sore by injecting in other places, but vermilion border injections would be a particular risk for triggering cold sores. On examination, it depends on the stage of the cold sore, which is something you should look closely at with images. Cold sores firstly start with a sensation of tingling, which your patient might tell you about. Then you normally get little vesicles on the surface of the skin, which gradually develop and then start to rupture. Following this, there is a scabbing over period, and your patient could present at any one of these different phases. The scabbing over period sometimes causes, as part of the reaction, a sense of fullness or lumpiness around the area. These usually would go away without further treatment. It's also crucial that these are very isolated. I have in the past seen people misdiagnose vascular occlusion necrosis with cold sores because they said it was just an outbreak all along the vermilion border, whereas in actual fact that was necrosis along the vermilion border. The cold sore should fit in with the patient's previous experience of having cold sores. It shouldn't feel like a different league of severity. And that is one of the things that might change your management or make you question your diagnosis. The next category of lumps and lips are substance-related lumps. And within substance-related lumps, there are two categories: acute and chronic reactions. Let's now consider the story that would go with an acute reaction. For most people, the patient may not be that different to other patients. Sometimes they may have had a similar procedure in the past that caused excessive swelling, and sometimes they may just report that they tend to be more inflammatory. So that would be someone who, for example, dermographia, if you scratch on someone's arm and they get a weald, that's a massive indication that they may have the same problem with an injection-related procedure. But that also helps you diagnose that it's probably not an infection if they've swelled too much, and that also it may be self-limiting, unlike other types of reaction. So the procedure itself also may indicate to you that this is a trauma-related inflammation, and that would be if the procedure perhaps was more traumatic than usual, or if you happen to know that the type of injection that they had was more likely to cause inflammation. One example of this might be those lip tenting procedures that I've seen some people do, where you cross the lip many times as you try and rotate the lip upwards. That is much more likely to cause excessive swelling and inflammation. Finally, they may have reported bruising soon after the procedure, and bruising is hugely inflammatory. As blood enters the skin, it triggers a cascade that triggers inflammation and healing. So it would be expected that someone who had a lot of bruising would also get a lot of swelling. The most excessive part of swelling normally occurs 6 hours after a procedure, but if you were having a reaction, that would persist for much longer, and often the next morning it's even worse, and sometimes even 2 days later you can still have excessive swelling if it is left untreated. So the development of swelling is also one way of proving whether it's a reaction or a traumatic type. The timing is very important. If the swelling that seems to occur after 6 hours is getting worse, that is one way of saying this is a reaction to the product rather than a reaction to the procedure, because procedure-related swelling tends to peak around 6 hours, maybe a little bit worse the next morning, but it should be recovering by 24 hours, whereas when it's product-related swelling, you tend to have swelling that goes on and develops from the next morning and gets worse. The story of a chronic reaction is quite different to many of the others, because it can evolve over such a long period of time. If you consider the type of patient this might be likely to occur to, it's often people are quite laid back and they don't necessarily want to fuss and cause a bother, and they basically ignore or falsely reassure themselves that it's nothing and don't seek help. They tend to let it go on for longer than the more anxious types who will be in front of you again quite soon so that you can help deal with it. So the procedure itself is likely to have very little to do with this as well. I mean, I don't think there's a big connection between the procedure, but there are some possible question marks over foreign bodies. So chronic reactions as a result of makeup being dragged into the tissue is one of the possible causes. So it might be that you are aware of a patient who doesn't take the advice not to apply makeup afterwards, or wears very heavy makeup ordinarily. And these things might become a factor that make you think possibly there is a chronic reaction to a foreign body occurring. The other thing, of course, is what's actually injected, because many dermal filler products are designed to stimulate a foreign body reaction. None of the HA products that I'm aware of, but many of the others, the most commonly used one would be Sculptra, and that actually stimulates the tissue to respond, and that is one of the possible downsides of using Sculptra, is you get lumps that develop very slowly over a period of months or even years that are very hard to treat. In terms of what the patient will experience, usually it's just a little bit of swelling initially, sometimes a bit of tenderness around the area that seems to persist, and they often think this is normal. So a persistent mild tenderness, maybe a little bit of redness, but it's not a big feature. And then often those symptoms actually settle, and what was a slightly soft lump turns into quite a hard, firm lump over a period of months, and they feel very different to anything you'll feel in in other settings because they're incredibly firm, almost solid, hard, rubbery feeling lumps. And they're very difficult to treat, and they form over a period of months. So on examination, that's what you're going to use to differentiate, is the firmness and the discreteness of these lumps, because a chronic infection tends to lay down quite a lot of collagen around the area and form these nodules, and they're very obvious to feel and different, and they usually will be 3, 6, 9, even 18 months after the procedure that you will actually get to see them. The final type of lump or lesion that you should be able to diagnose are the non-procedure, non-product related lumps that are part of normal human physiology, or sometimes are pathological in nature, but it would be a good idea for you to understand the basics so that you don't contribute to a missed important diagnosis. There are, broadly speaking, 6 different categories of non-treatment related lumps that you will see quite often in clinical practice. And one of those actually you shouldn't see very often, which is a mouth cancer, but I want to discuss that as well so that you're prepared to at least direct people in the right direction if you're concerned about one of those serious causes. So let's consider one of the most common presentations after a procedure, which is a complaint of little white dots on the surface of the lip. And these are actually Fordyce spots. Interestingly, about 80 to 90% of people have these on one or more of their mucous membranes, and particularly on the lips. You see them after a procedure. So what I believe is happening is the patient has a normal procedure and then examines their lips quite closely afterwards. What they will notice are spots that they may not have noticed before for 2 reasons. One is they haven't closely examined their lips for a long time and they've never noticed them. And secondly, the redness or inflammation is highlighting the contrast between these pale spots and the new brighter, redder background, so that you see in much more detail that these little tiny dots. Essentially, they're only sebaceous glands, and we all have them, 80 to 90% of us have them on our bodies, and they're nothing to worry about. They're not pathological, they won't develop, and they're not caused by the lip procedure, but they can be revealed by the lip procedure. So the patient usually presents straight away, and they tend to be more of an anxious type of patient. They tend to had a little bit of doubt almost when they came and left. They may have just been looking for more reassurance, and those people tend to go away and look for problems, and they often will pick up something that's always been there and feel that it's different and sometimes upsetting, even though it's always been there. The procedure is unrelated. I don't think there's anything about the procedure that would cause this, but inflammation from any of the ways that you could do a lip treatment might increase the chance of someone seeing it. The symptoms will be none except for seeing them, and on examination you should just see little tiny white dots around the oral mucosa. Tend to be a little bit on the inside of the mouth as well, but once you've seen them once and maybe had a look at a few pictures online, they're an easy diagnosis and you can give emphatic reassurance that there's nothing to worry about. The next category of non-procedure related lumps is mucoceles. Mucoceles are a very common experience of basically minor trauma to a salivary duct that decreases the flow of saliva out of the tissue, and you get a build-up which looks a little bit like a bubble of saliva. They tend to be painless, and they tend to also go away on their own within 3 to 6 weeks. The trauma associated that causes them is normally to do with the top and bottom teeth meeting and biting rather than the trauma of an injection, because also we tend not to be on the inside of the mouth when we're injecting. If the procedure did involve an accidental penetration into the inside of the mouth, it's possible that you could cause a mucocele, but also doesn't change the management, and this scenario should be highly unusual. Symptoms of a mucocele are simply a little bothersome lump, usually on the inside of the mouth, near where the incisors meet, and it's painless and it feels firm, and if you just wait for long enough they go away on their own. They're usually between 2 and 10 millimeters when you examine them, and they look very isolated, very clearly like a bubble as opposed to a diffuse structure that's blended in with nearby structures. You should on examination be able to diagnose them quite quickly with the help of looking at some images which will help you embed in your mind what they look like. One other way to differentiate them from dermal fillers is to massage them. A cyst will usually be quite firm and difficult to rupture, whereas if it's a lump of dermal filler, you should be able to massage it away and squeeze it into the deeper tissues fairly easily if this is quite soon after a procedure. If the lump feels mobile and seems to be deeper rather than in the surface, this could be a lump of filler or a reaction nodule, delayed onset nodule that you're palpating that looks a little bit pale, but the way that it's mobile and moves away from the surface would tell you that this is not a mucocele. Mucocele should be in the top layer of the skin surface on the inside of the mouth. Aphthous ulcers are also a very common presentation after a lip treatment. Most people tend to self-diagnose and don't bother you, but occasionally people will worry and think that this is a complication from the dermal filler. Aphthous ulcers tend to be associated, if you consider your patient's condition, with stress and sometimes, and more often than not, actually a previous history of having a similar condition. They sometimes are associated with serious systemic disease such as ulcerative colitis, and it's worth considering this in the bigger picture when you see your patient. In terms of the procedure, it's unlikely that the procedure is directly related, unless perhaps there was some trauma to the inside of the mouth, which, as we've said, should be incredibly unlikely. The symptoms of an aphthous ulcer are a painful ulceration, usually on the inside of the lip, that is painful to touch and has inflammation clearly around it, which should get quite tender and painful, and then should fade and recover quite quickly. Any non-healing ulcer is one of the possible signs of an oral cancer, and you should refer these people to see their GPs. When you examine them, you should see an ulcer that looks as this picture illustrates and should be a little bit inflamed and tender to touch. It's important to note this ulcer so that if you review them again and they have something similar in 6 weeks, they get urgently referred to see their GP. The final and most serious possible cause of a lump would be an oral cancer. Now, it's often the case with your patients that they will start to notice things that they haven't noticed before after procedure. And in this case, you tend to have treated an older person with possibly some risk factors for oral cancer, such as high alcohol intake, particularly of spirits, and smoking. And these things would make you think differently about a lump that seemed to have been noticed soon after the procedure and then seems to persist for a long time. In general, oral cancers are either flat and white discolorations onto the inside of the surface, which would be a little bit less likely to present to you as an aesthetic practitioner, and the other ones are more irregular or nodular lumps that often occur on the inside of the cheek and possibly the lower lip as well. And the key hallmark difference between these lumps and others is their persistence and obviously the fact that they grow. So an ulcer that doesn't seem to be improving for weeks, or a lump that's there and isn't improving in someone with risk factors, it's really important that you ask them to see their GP and don't hold on to this yourself. The moment they have asked you and you don't know what the diagnosis is and you think it could be this, you should refer to the GP to make sure that all your bases are covered and that you haven't missed an opportunity to diagnose early a serious and life-threatening condition. So in the next section, we'll look at how to manage these various different types of lumps so that you can instill confidence in your patients and diagnose and treat quickly and accurately so that you can protect your reputation and look after your patients. If you're interested in finding out more about how to treat patients in a way that minimizes lumps and lips, check out the Lip Masters full course, which is available on the link below.